Hello, my name is Katie Fessler, and today is Monday, December 2nd, 2019. Today I will be presenting my case connections for Unit 4. So to begin, we will look at Case 2, which is an investigation of phenylketonuria. So in this case, we're considering a newborn who's suspected to have phenylketonuria. The patient is displaying symptoms of this condition, but the parents deny any family history of it, which is significant because phenylketonuria, or PKU, is a genetic condition. You would therefore expect that there would be a family history of the condition. However, PKU is a recessive mutation, and there is varying degrees of severity, so it may just not have shown up yet. We can see here, though, that the patient does have elevated levels of phenylalanine in their blood. So PKU is an inborn error of metabolism that causes an accumulation of phenylalanine in the blood. In normal metabolism, phenylalanine hydroxylase will convert phenylalanine to tyrosine. However, in patients with PKU, phenylalanine is unable to be converted to tyrosine, leading to an excess of phenylalanine and insufficient tyrosine production. This causes physiological, neurological, and intellectual disabilities. Now, for normal metabolism of phenylalanine to proceed, the enzyme phenylalanine hydroxylase requires this tetrahydrobiopterin, or BH4, as a cofactor. When phenylalanine hydroxylase is functioning properly, tyrosine is a non-essential amino acid, provided that there is enough phenylalanine in the diet to supply conversion to enough tyrosine. The enzyme will convert phenylalanine to tyrosine as needed. However, in the case of PKU, where there is not enough enzyme activity, tyrosine will become essential as the body is now unable to produce the amino acid. Individuals with PKU must therefore get tyrosine from their diets. PKU is often treated by removing phenylalanine from the diet and supplementing tyrosine. In this patient, when phenylalanine was removed from the diet, blood levels dropped to within normal range. This supports the diagnosis of PKU. Now, broadly, PKU is caused by a decrease in the activity of phenylalanine hydroxylase. This may be due to several causes. First, and most obvious, there may be a deficiency in the phenylalanine hydroxylase produced. Without the enzyme, the reaction cannot proceed, and phenylalanine will build up. However, there may be cases where there is enough functioning enzyme, but the reaction still cannot proceed. Let's look at the activity of the enzyme to understand how this may be. Phenylalanine hydroxylase requires BH4 as a cofactor. Without it, the enzyme cannot function properly. Aiding in the hydroxylation activity converts tetrahydrobiopterin to dihydrobiopterin. This can then be reduced back to tetrahydrobiopterin by dihydrobiopterin reductase to aid in future reactions. In PKU, it's possible for there to be enough phenylalanine hydroxylase available, but insufficient BH4 available. This could be because BH4 is not initially produced, so it's not present at all to act as a cofactor. It may also be that there is initially enough BH4, but no dihydrobiopterin reductase. Without this enzyme, the dihydrobiopterin cannot be reduced back to tetrahydrobiopterin, slowing or inhibiting the conversion of phenylalanine to tyrosine. Whatever the cause, the result is the same. Phenylalanine will be ineffectively converted to tyrosine, leading to a buildup of phenylalanine and a reduction in tyrosine. Now, in this case, there is a second infant being evaluated for PKU. Both babies undergo a BH4 loading test. In this test, they are given synthetic tetrahydrobiopterin, the cofactor for phenylalanine hydroxylase to function. Their blood phenylalanine levels are tested before and after receiving the synthetic BH4. Here we see the results for the test. For patient A, phenylalanine levels continue to rise after BH4 administration. From this, we know that dosing with BH4 does not help to control the PKU. Therefore, we can assume that the problem does not have to do with BH4. For patient B, we see that the blood levels of phenylalanine decrease over time after receiving BH4. it appears that BH4 treatment is helping to reduce the effects of PKU. This implies that there is not an issue in the phenylalanine hydroxylase because it seems to function with BH4 present. It seems that instead, there's a problem with the availability of BH4. From these results, it appears that the two babies have different causes of their PKU. Patient A seems to have a deficiency in the phenylalanine hydroxylase enzyme itself. Patient B, however, seems to have a deficiency in the availability of BH4. The next case we will look at is case 3, which is an investigation of gout. Now in this case, we are presented with a 47-year-old male with severe pain in his toe that has occurred with no apparent trauma. The suspected cause is gout. Blood samples and a urinalysis demonstrate that the patient has high levels of plasma urate and low levels of urinary uric acid. But what can this tell us about the cause of his gouty arthritis? First, let's consider what gout is. The human body can synthesize purines. These purines may then be converted to uric acid. Uric acid is insoluble, and once a certain concentration is exceeded, it will begin to deposit urate crystals in soft tissues and in joints, causing pain and damage to those tissues and joints. It's caused by multiple mechanisms that ultimately lead to this too high concentration of uric acid and therefore deposition of crystals. This may happen because of an overproduction of purines or lack of clearance of purines, increasing the concentration and increasing the amount of uric acid produced. However, it may also be the case that a normal number of purines are synthesized and cleared, but that there is a decrease in the urinary excretion of uric acid. Purines are nucleic acids. They include adenine and guanine. They're part of the structures of ATP and GTP. They can be produced by the body. In de novo synthesis, the complicated reaction seen here, the first step is the transfer of two phosphoryl groups from ATP to ribose 5-phosphate, forming phosphoribosyl pyrophosphate. This reaction is catalyzed by PRPP synthetase. Dysfunction in this enzyme is often a cause of gout. The enzyme may not be regulated properly, it may have an increased Vmax, or it could have an increased affinity for the substrate. This then goes through multiple steps to produce IMP. IMP is then converted to AMP and GMP, as we see here. The body will then continue to convert adenine and guanine to uric acid, as we see here. Uric acid must be excreted from the body as it's insoluble and will ultimately begin to produce urate crystals, the urate crystals that we talked about earlier if concentrations are too high. This excretion is primarily through urinary excretion. However, some may be excreted through the intestines. Now there is another way for purines to be synthesized. Cell turnover can release purines. This increases the concentration of free purines that may become uric acid. To prevent overloading the amount of uric acid that must be excreted, purines may enter the salvage pathway. This allows them to be converted into AMP, GMP, and IMP rather than to become uric acid. Now let's go back to our patient. What makes sense as the cause of his gout? Overproduction of purines? When we look at his lab values, we see that there is an elevated plasma urate level, so it seems reasonable that too many purines may be produced. However, notice that the urinary uric acid is lower than typical. We can at least say that overproduction of purines alone is not the cause, because there's clearly an issue with urinary excretion as well. Okay, let's look at the next choice. Decreased salvage of purines. This could also be the cause. Decreased salvage of purines would certainly increase the plasma level. However, again, we can't say that it would be due to this alone because of his reduced urinary clearance. It would be helpful to see concentrations of AMP, GMP, as well as potentially levels of the enzymes involved in the conversion of purines on the salvage pathway. Finally, consider decreased urinary excretion of uric acid. This seems very reasonable. There's certainly decreased urinary concentration of uric acid based on his lab values. This could lead to the increased plasma urate levels we see on its own without needing another mechanism. it seems reasonable to conclude that decreased urinary excretion is the cause of this patient's gout. However, we later learn that our patient has recently made a dietary change that drastically increased his fructose consumption. Fructose bypasses the regulatory step in glycolysis, catalyzed by phosphofructokinase, going right to fructokinase. High dietary fructose will also reduce ATP synthesis. Together, these factors will increase de novo synthesis of purines. Our patient's recent dietary change has likely led to a great increase in the amount of de novo synthesis of purines. This may change what we think is the cause of his gout. It still seems reasonable to believe that he has a deficiency in his urinary excretion of uric acid. However, it seems that his body was likely able to make up for this with the salvage pathway and with regulation of the pathway for de novo synthesis of purines. However, the extreme amount of fructose is likely overriding those checks and balances. There are now too many purines being produced for the salvage pathway to help compensate for. The combination of this increase in de novo purine synthesis, which will lead to increased uric acid, and his decreased urinary excretion, has likely led to his onset of gout symptoms.